Good morning, everybody. My name is Mike Willett at the Intertribal Council of Michigan, and at the Intertribal Council of Michigan. Welcome to our webinar today. This webinar is titled Provider and Client Reminder and Recall Systems to Increase Colon Cancer Screening. Your presenter today is Thomas Rich, MPH, Health Systems Manager from the American Cancer Society. We are pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated 1.75 contact hours. And to obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. By the end of this webinar, participants will be able to examine the current colon cancer disparities among the American Indian population of Michigan, apply current clinical guidelines to screen and detect colon cancer, and implement a system of alert clinicians and inform patients who are due or overdue for screening. If you have any questions, please type your questions into the question box on the lower right-hand side of your screen. Questions will be answered during the last few minutes of the webinar. Also, just as a little bit of housekeeping, we are going to break the webinar up into two portions. There will be a question and answer session roughly at about 8:45. We'll answer questions for about 10 minutes or so until about 8:55. We'll take a 5-minute break, and then we will resume the webinar at about 9 o'clock. Thank you very much, and at this time, I will turn it over to Thomas Rich.
Well, thank you, Mike. I'm happy to be part of this. The American Cancer Society and the Intertribal Council has been working together for as long as I can remember. I've been with ACS for 12 years, and all during those 12 years, we've had a close relationship. And what I've come to find out is that relationship existed before I was even here. So this is just another way that our two organizations are collaborating to address the cancer burden for the Native American population here in Michigan. What we're going to talk about first is provider reminder and a recall system. This is a evidence-based practice that is out there, and it's one way to increase colorectal cancer screening rates. So Mike went over some of the objectives, and these are in more detail. As he said, there will be a time for you to put your questions into the chat box, and we will address those later in this presentation. If there's something that you see here that I do not address, by all means, please say something. So why is colorectal cancer screening important? It's overall in the United States, it's the second leading cause of death in for men and women combined. In the Native American community, it is the third leading cause of cancer death in women and the second leading cause of cancer death in men. Overall, cancer is this #1 cause of death for Native American women. This is data that was published in 2014. So we know that colorectal cancer is preventable. This cancer develops from the polyps, as you know, that are in the intestines. And screening can detect these abnormal polyps before they become cancerous. This is either done visually through a scope or by detecting blood in the fecal matter. And So screening is important to do before the cancer actually develops. It can prevent the cancer, or if colorectal cancer is caught early in that stage 1, it is the treatment outcomes are a lot more successful than if it's caught in a later stage. So these are the screening rates among IHS users, and this is reported by the GPRA. And you can see they're rising some, but they're the latest one in 2016 is about 40%. Now the healthy people goal is 70.5%, so there's this 30 percentage points gaps. In Michigan, the BRFIS data that was published for 2016, the overall colorectal cancer screening rate in Michigan runs about 70%. So you can see, even though this isn't specific to Michigan, that there is this gap. This is more information, and this looks at the IHS data by regions, and we can see that our region, in the Bemidji region, where it looks like we're better than some, but not the best out there. So Michigan is above the 2016 target, but it is far from the 70% that that we would hope to be at. So if a clinic wants to increase screening rates, if a clinic wants to do anything, the first thing is to make it a priority. And there are competing priorities in all settings. We know that. You know that better than anyone. But considering the effect and the burden of colorectal cancer, it's a worthwhile priority for a clinic to do. And if you're going to have a priority, you need to come up with a plan. So this is a toolkit that was developed by the American Cancer Society in cooperation with the National Colorectal Cancer Roundtable and Thomas Jefferson University. And it's a practical manual on how to develop this plan, not only for colorectal cancer screening rates, but all kinds of screening rates. As with any with any strategy, there's this continuous improvement that you model that we follow, and that is develop and test the changes of what you're doing. And those are summarized kind of with the plan, the act, the study, and the adjust. Now, this manual gives 4 essentials for improving cancer screening rates. When you're developing your plan, you need to do it in cooperation with your staff and develop a screening system based on these 4 essentials of making a recommendation, developing a screening policy, being persistent with reminders, and measuring practice progress. If you already have a system in place, review your approach and identify opportunities for improvement. You need to establish a baseline screening rate before you implement any changes to test the effectiveness and the efficacy of the intervention that you're doing. You need to act on your plan. And again, you need to engage your staff with the plan and make for sure everyone on your team knows your role. It can't be the responsibility of the provider. It can't be just the responsibility of the nurse practitioner or the health worker or the receptionist. It's got to be the it's got to be something that everyone in the office is involved with, and that everyone knows what they're supposed to be doing. You need to study your results, measure your screening rates, and meet with your staff regularly to review the progress that you're having or lack of progress. And if nothing else, you need to adjust your plan. And this is based on your results, identifying opportunities for further improvement. When you are ready, build on your plan and consider harder to reach patient groups, which we'll get into in a little bit. So the first essential is to make a recommendation. Evidence accumulated over 2 decades shows that a recommendation from a doctor is the most powerful single factor in a patient's decision to be screened for cancer. Assess the patient's risk status, discuss their needs, and offer several test options to increase the likelihood that a patient will get screened. Not all colorectal cancer screening tests are going to be viewed with equal enthusiasm by all patients, and we'll get to that in a little bit later. At a minimum, offer a choice between a high sensitivity multiple sample stool blood test and a colonoscopy. And just be aware that members of minority or low-income groups, individuals with less formal education, and older adults are less likely to be given a screening recommendation. So part of that is this inherent or perceived notion that people are either set in their ways and won't do it, or that they don't understand the procedure, or it may be something that they're not insured, or it's too costly. So the second essential is to develop a policy. And a policy should outline the screening program. If colonoscopy capacity is inadequate, which is true in most locations, an annual FIT or GWAIC-based stool test for age and risk-appropriate patients is a practical and evidence-based approach. Colonoscopies must also be available for patients at higher risk or for diagnostic purposes following positive stool screens. So if your clinic decides to go strictly on the blood stool test, there still needs to be an agreement with someone who can do the colonoscopies for those high-risk patients, or those patients who end up with a positive test result. Consider the following when developing your screening policy: national screening guidelines, the realities of your practice, patient history and risk level, patient preference and insurance coverage, and local medical resources. So the third essential is to be persistent with reminders. Now the second presentation that will be starting at 10, we're going to talk about client reminders. In this hour, we're talking strictly provider reminders, and it has to be this. It has to take place all the time for all age appropriate or risk appropriate people. For providers, you can use chart props, ticklers and logs, and electronic medical records can provide the cues for physicians and their teams to take action. And we'll talk about that in a little while too. Postcards, letters, prescriptions, in-person conversations, and phone calls can encourage patients to follow through with the screening. It is important to record when a recommendation was given, the type of test recommended, and the test result. If additional follow-up was needed, track and record whether a referral was made and what follow-up tests were performed. Actively monitor whether screening and all necessary follow-up tests are completed in a timely manner. In the case of a positive stool blood test, do not repeat the test and always refer a patient for a colonoscopy. One of the nice things about this toolkit is it contains templates that that would have allow you to put all this information in there. Your EHR may do that too. If not, by all means, look at these templates, and it saves you from trying to create something. You can if you want, but sometimes it's easier to borrow than to make it yourself. So the fourth essential to increase these rates is to measure your practice progress. Staff should keep track of all referrals and all stool tests. If a stool screen is positive, the patient must be contacted to arrange for a colonoscopy. If the patient is a no-show for a colonoscopy and needs rescheduling, making a personal contact with him or her will make a difference. Responsibility for follow-up and rescheduling should be an explicit understanding between the health center and the specialist and reflected in the health center screening protocol. During staff meetings, allow time for your team to report what is working well, what can be done differently, whether documentation procedures need improvement, and if there are additional ways to support members of the team. Elicit feedback from your team and your patients to learn valuable information about opportunities to improve your system. It is essential to complete one review that will serve as a baseline of comparison for all future audits. An initial audit can be completed simultaneously with the baseline review. So when we talk about provider recall and provider reminders, what are we talking about exactly? The goal of the provider reminder and recall intervention is to increase delivery of appropriate cancer screening services by healthcare providers. The premise behind this is that by increasing provider awareness of their client's cancer screening status, either through a reminder that the client is due for a screening or by a recall that indicates the client is overdue for screening, the intervention would increase chances that the provider would discuss screening with clients, recommend screening, and order screening tests. These would influence client behavior and lead to increased test completion, which in turn would lead to early detection and ultimately to reduce cancer morbidity and mortality. Some considerations that you need to be aware of. Provider reminders may increase the use of other preventive services linked to the system. So if you have a 52-year-old woman that is coming in for a colorectal cancer screening, it may lead her to have a mammogram, or vice versa. If this woman is getting a mammogram every other year and not getting the colorectal cancer screening, it's a good opportunity for the staff to raise that question and just say, you know, you're doing this good thing, you're screening for cancer. Colorectal cancer is deadly too. Possible barriers are this administrative burden and lack of information technology infrastructure of a provider, of using a provider reminder system. So if you're EHR is unable to adequately remind you who needs screening or not screening, or if the record keeping is lagging, that that any new screenings not placed into the record, then it won't pull up on the EHR. That Sometimes it's difficult if a provider wants a list of patients that they're going to see in that week that are age appropriate and haven't been screened. And some providers like to have this list generated, and your clinic is not able to do that, then that's a potential barrier. Provider reminders are intended to reach people who receive health care, right? So they have to come in before you can tell them, let's talk about colorectal screening. This may not be the best approach to use in communities with limited access to healthcare or among groups who underuse healthcare services. And in a little while, we'll talk about setting priorities on who you want to screen. In selecting an intervention to increase cancer screening, consideration should be given to the overall population screening rates, location and identity of populations in greatest need, opportunities to deliver specific interventions, availability of tracking systems, and local context, culture, needs, and screening history. So if we're going to screen people, what are we using as our screening guidelines? And these are those put out by the U.S. Preventive Services Task Force. I don't know if anyone uses anything but these. Usually payers, health plans, Medicaid, Medicare use these as their guidelines. These have been in effect for quite a while. They were redone or updated, I guess, since 2016 to now include FIT DNA test and the CT colonography. I know I'm pronouncing that wrong, but with not all health plans will pay for the use of either one of those two. So really the FOBT, the FIT, the colonoscopy, and the Flex Sig are those that are normally used for screening in most clinics. So where do you start? So you have a strategy, you have a goal that you want to increase colorectal cancer screening. You are putting your plan together, and it would be nice to say, we want to screen everyone that's not been screened. Okay, that's a good goal, and that may be an achievable goal down the road. But a lot of times you want to start with that low-hanging fruit, right? That you want to get those people that seem motivated, or at least the people that you're seeing, to talk with them and work with them first. So kind of this hierarchy of patients would be those who are coming in for regular checkups. So two things that you know about these people. One is they're coming in once a year at least. And the second is, because they're coming in, they care about their health and they're motivated to take care of themselves. So if you have a regular patient, it is easy to say to them, you come in, we give you this exam all the time. You're now 50 years old. Have you ever thought about being screened for colorectal cancer? It's preventive. It's a deadly cancer, and I know you care for your health. The next one would be those who come in for preventive services. So again, we talked about the woman who may be getting her mammogram every other year, but has yet to have a colorectal cancer screening. This is true too for people who are coming in for flu shots. What a good time to talk about being screened for colorectal cancer. In fact, there's an initiative called the Flu Fit that is available through the National Colorectal Cancer Roundtable and the American Cancer Society, where people who come in, age-appropriate people who are coming in for a flu shot, are given a fit kit to take home. So again, you already have that motivation there. Patients who have been screened before, so if people are taking, if how they're being screened is through a fecal blood test, and they've done it for a couple years in a row, and then they stop doing it. There may be a reason there of they forgot or nothing has changed, and so this is the opportunity to reach them too. And then people with chronic conditions, people who only come in when they have a problem, and people who seldom come in. So need to choose the right test. Do you want to do the fecal blood? You want to do the colonoscopy? A lot of this depends on family history. If they have a family history of polyps, then by all means the colonoscopy. If they're at average risk, then it's a good opportunity to talk with people about the flu, about FIT or FOBT. And that brings us to patient preference. So there's been several studies done on, if given a choice, what patients, which colorectal cancer screening they prefer to do. And there are people who are opposed to both. So some folks may say, I don't like the idea of the colonoscopy. I can't take off work. I can't for 2 days. I don't have transportation. I just don't like this invasive procedure. The advantages would be you only need to do it for every 10 years. So once it's done in your lifetime, if you start at age 50, you would do one between 50 and 60, one between 60 and 70, and one between 70 and 74. So just 3 as opposed to 25 that you would need to do if you took the FIT or the FOBT. Some people just don't like digging in their own poop too. So they may be ones that prefer the colonoscopy. We know though, but by offering choice, it increases screening uptake. And as such, the screening test shouldn't be presented in any preferred or rank order. The goal is to get the patient to choose which screening method is best for them. This is a study that was done back in 2012, and they separated age-appropriate people into 3 groups. One, they only gave the choice of an FOBT. The second group, the only choice they gave them was colonoscopy. And the third group, they said you could either have a colonoscopy or an FOBT. And these are the completion rates here. So by far, those who had the FOBT were more likely to complete their screening than those just offered the colonoscopy. And when given a choice, the the screening rate was better. Colonoscopies, as I mentioned, do have some limitations. And if you're not doing a colonoscopy, then there are different types of the stool test, FOBTs, and then the FIT. You need to be careful selecting an FOBT. A lot of the earlier ones and the cheaper ones do not have that high of a sensitivity or a specificity. And so you always want to check on which ones rate the highest. And if you don't know what that is, NCCRT has that information. And again, at the end of the presentation, there's some resources listed, and then in the folder is also a list of resources that will direct you to things such as this. Again, the new kid on the block is the DNA. So we know that colon cells are continuously shedding, and the polyps and the cancer cells contain this abnormal DNA. And what the stool DNA tests look for is this abnormal DNA that are passed in the stool. Again, using these are somewhat expensive, and they may not be covered by all health plans. So, your clinical screening strategy. What are you doing to make sure eligible patients are being screened? So for this, you're instituting a provider reminder and recall system, right? So you're doing that. Are you using evidence-based interventions to screen for colorectal cancer? And again, provider recall and reminder is one aspect of it, but you need to prepare the patient through awareness, maybe even client reminders, which we'll talk about at next hour, and these kinds of things. You don't have much time in that visit that you are spending with the patient, and so anything that they know beforehand is always helpful. What have you done before to increase these screening rates? Have you had a recall system? Have you had a provider reminder system? If so, has that worked or has it not worked? And if it hasn't worked, then what have you done with other diseases where the provider is talking to the patient that has been successful? So again, this is one of the templates that are available. This is just a worksheet that you could go through and utilize. So you need a policy, and this is a policy from a health plan, from a health system in the East, and I wish I could remember which one it was. So they've went and put this policy together. And as you can see, the medical assistant has a role, and what they do is prepare things for people that are going to be coming in that week and giving that to the provider. So they're alerting the provider already of, here, these people are coming in, and these are the ones that need to be talked about to recommend a colorectal cancer screening. Now, you could do this where the provider is given this information, or as an alternative, you could just have standing orders. and that anyone 50 and above that comes into your practice are either referred for a colonoscopy or a sigmoidoscopy, or they're headed a FIT kit. And that's what you do. The advantages to this, it's really pretty easy that you're gathering everyone in this age group that that would need screening. The disadvantages, again, it's only reaching those patients coming in with the healthcare system, and there's little or no opportunity for patient input. So if you have a standing order that everyone 50 and above needs a colonoscopy, you might not get that compliance. So even though you could have this standing order, if you do that, by all means, what you need to build into it is time to discuss the options with the patient. What most clinics do is what they call these chart reminders, and they can be simple as a colorful sticker on the chart, or they can be a comprehensive checklist of preventive services that need to be done. They could be they need to be prominently placed in the chart, and those that have some kind of acknowledgement from the provider are more effective than just a single reminder. Talk to Anne about being screened for colorectal cancer. So if that provider has to put a check mark on there that yes, indeed they did, and not only that, but they have to give what happened from that conversation. So talk to Anne about being screened for colorectal cancer, discuss colonoscopy. She did not like that option. We talked about FIT, and that was more agreeable to her. So she was given a FIT kit. A lot of the EHRs now have those as pop-ups. However, a lot of times those pop-ups can be turned off, or if you're consistently getting a pop-up, it may be ignored. So they're easy to ignore too. So what are some of the barriers to doing this? So it's medical practice is usually this patient-driven. There may be a call that goes out to the patient that says you are due for your yearly exam, but a lot of times people don't do that. So it's based on the patient has to come to you. Patient demands are numerous and diverse. So it's not only colorectal cancer that you're trying to deal with, it's all kinds of other cancers, all kinds of other chronic diseases. And by the way, it's also flu season that you're doing that. Again, we talked about the mechanisms to assure that people get screened. There's this knowledge and skills of the provider, a lack of knowledge about guidelines, impact of family history, higher risk in the American Indian, Alaska Native population, lack of knowledge about the FIT and the FOBTs, and the use of older, less effective guaiac, FOBT, and in-office digital rectum exams, which you should never use to do a blood stool test. Extraneous barriers would include provider turnovers, limited time with the patient, understaffing, poor EHR reminder and tracking systems, lack of qualified staff, lack of awareness of screening rates among providers, and unreliable screening data. Some of the barriers to the my thing is not advancing here. Okay, Mike, I can't seem to advance the screen.
Yeah, for some reason it looks like it's just kind of spinning busy right now. Let me see what I can do here.
Okay.
Yep, we kind of locked up for a second.
Okay, there we go. Okay. So these are the provider barriers. Mike, we're back on your screen.
Hmm.
Yeah.
Yeah, I'm trying to figure this out here, and I'm not sure. Let's see. Yeah, I'm trying to escape out of the PowerPoint. That's not working either.
Okay.
So we're frozen up at the moment.
Okay, so while you're trying to unfreeze that, let me just go over some of the barriers that patients may have. Affordability, lack of symptoms, no family history, more pressing health issues, negative perceptions about the test, no regular primary care to reinforce the message, and probably the biggest one, the doctor doesn't recommend it. So if we look at measures to improve performance, a program measures its success by demonstrating an improvement from baseline screening rates. Some programs have found it helpful to provide monthly screening rate reports, allowing for ongoing reevaluation in the process. It is important to include collecting, monitoring, reporting data, ensuring through documentation of screening tests the results, tracking, and follow-up, gathering feedback from staff, patients, navigators, clinicians, and especially providers, specialty providers. So the GIs doing the colonoscopies.
I'm trying to restart the PowerPoint.
Yeah, that's fine. I'll just keep going. Measuring outcomes. So if you again, this your strategy, your priority is increase the colorectal screening rates in your practice. The way that you are doing this is through one of the components that you're using to do this is through provider uh, reminders and recalls. So how do you measure? There we go. How do you measure your success? Yeah. So you can obviously it's by who's getting screened and who's not being screened. So by computing this your screening rates and to to kind of increase this to increase this, you can compare screening rates among providers in a clinic. And if there's just one provider in the clinic, then you may want to set some other standard. But if there are more than one, you could compare those two to one another. And you can either do this, you can identify the person and say, Dr. A, your screening rate's 40%, but Dr. B, yours is 60%. So what this does is it gives this recognition to the one provider, and it allows the other provider to say, gosh, what are you doing differently that you have more buy-in than what I'm doing. If you besides looking at comparing providers in one clinic, if you have several clinics, you can either compare the clinic's rates against one another, or the providers, group all those providers together. You could do the same with the whole tribal health system in Michigan, that you could, all the different health systems could compare their rates, and these rates would be published. And again, you could either do that by identifying the particular clinic or tribal health clinic, or not doing it and letting each one know where they stand as compared to the others. If it is published and the names of those tribal health clinics are given, that's kind of known as the embarrassment factor. That once people see that it's you that is either underperforming or overachieving, then it either embarrasses you or it makes you feel proud. So that is something that you would need to discuss. We're running out of time here. Calculating screening rates, again, your payers, the health plans are using this, either HEDIS measures or the CMS measures. And these are, again, those recommendations are based on the U.S. Preventive Services Task Force. There are two ways that you can calculate their rates. Either the direct method, which you take all age eligible people as your denominator, subtracting those who have had colorectal cancer or who do not have a colon, and the numerator of being those people who have had any of these tests within those timeframes under the guidelines. When you come up with your screening rate, most times it's underreported. And the reason it's underreported is because clinics, it's sometimes difficult to capture everyone who has been screened, or if they have been screened, of getting that recorded and entered into the record, especially in March. March is National Colorectal Cancer Awareness Month. And what happens a lot of times, there are health systems that distribute free fit kits, or sometimes health plans will do that. So if it's worthwhile talking to a patient and just asking them, have you been screened for colorectal cancer? And if they said, yeah, you know, I got this fit kit from my health plan, and I did that about 6 months ago, and my results were negative, then that needs to be documented and put into the chart. The other method is a sample method. I would talk to your QI folks about doing this. There's various ways that you do it. It's a bit too involved to go into detail here. So as I said, there are many resources out there. This communications guide is great on how to reach those who are unscreened for colorectal cancer. There was focus groups done, and it identified some motivators and some reasons why they're not screened. And we'll talk more about that in our next in the next hour. The other is the NCCRT, the National Colorectal Cancer Roundtable. If you go to one site only, go to this website. It has everything that you ever wanted to know about colorectal cancer screening. It's full of toolkits. It's full of templates. It's full of presentations. It's got everything in there. Finally, If I can advance the slide. Mike, if you can advance that for me. Yeah, there we go. So other resources, the American Cancer Society, we have a whole section on our webpage, MD. Again, this has other toolkits in it. It's got cancer screening guidelines, cancer presentations, free continuing medical education units available there, and free access to our journal. Also, the American Cancer Society Circle of Life. This is a cancer education and wellness initiative that was developed with the tribes um, about 10 years ago. So they have good information. Okay, questions?
Alrighty, and if anybody has any questions, feel free to go ahead and post your questions into the question box. We're gonna probably just take a couple few. That way we can take a break for a few minutes, and then we'll start back up at the top of the hour at 10 o'clock. So the first question I have here says, can't read the whole thing. Technology has been awesome today.
Mike, while you're looking for those questions, let me also say as a resource, you have resources among your members. Keweenaw Bay does an excellent job with their colorectal cancer screening. Bay Mills in Brimley does an excellent job. Both of these tribal clinics have made colorectal cancer screening a priority. So if you haven't already, talk to some folks in either one of those. And there's probably other tribal health clinics that are doing a good job too. But reach out to your peers and see what they're doing and see how their rates are.
Okay, this person says, how might the practice of the institution of standing orders for CRC screenings for patients over 50 years impact clinic awareness for CRC risk assessments for patients who are less than 50 years of age?
Okay, what was the last part of that, Mike?
Okay,
so,
it says,
so the standing orders and how would it do what now?
how might the
Why would it be more confusing to those people? That's that's just what the evidence is saying that the maybe people older than 60 may be more inclined not to want to take the advice. They may take the advice of their provider. So there always seems to be this resistance, somewhat the older that we get up to a point. There's also that resistance sometimes in that 50 to 59 age because people feel that they're healthy. I'm not sure if that adequately answers that question or not.
And then
The advice would be try the standing orders and see if those work for you. It may be that you're not going to see that resistance.
okay. So if that answered the question, go ahead and type it in the question box. If you didn't, if you still had another follow-up question to it, feel free to post it in the question box. So yeah, we do have resources that are in the handouts section of the GoToWebinar platform as well. So go ahead and click on that on the lower right hand of the screen. So the person followed up. They say, do standing orders for those over 50 years of age detract from the risk assessment of patients less than 50 years of age?
Do they detract from the risk assessment? Well, if they're 50 and over, they're age appropriate. So the risk assessment, the only assessment, the risk assessment might then be that if they have a family history of polyps, then instead of the FOBT or the FIT kit, the standing order may be for these people, you need to be scoped.
Okay. So, yeah, I'm not seeing any other questions come in right now. So if we want to go ahead and take a little break here, we'll go ahead and start probably at what, like 10 o'clock, you think?
Yep, 10 would be good.
All right, so we'll go ahead and start back up at 10 o'clock, and we'll be right back. And we're back. It's straight up 10 o'clock. Tom, are you there?
I am here.
Awesome. All refreshed and ready to go for round two?
I think so.
All right. So we'll go ahead and continue on here.
Okay, so welcome back. So before the previous hour, we talked about the evidence-based practice to increase colorectal cancer screening rates, which was provider reminders and provider recall. This hour, we're going to talk about client reminders, which is another evidence-based practice. Direct contact with the patient is an evidence-based intervention to increase cancer screening rates. This member-directed initiative advises clients they are due or overdue for screening. Reminders can be delivered in different ways and in various forms. So before we talked about the colorectal cancer um, rate in for American Indians and Alaska Natives, I'm not going to go into a lot of detail here because I'm thinking the same people who were on the previous webinar on last hour are the same ones here. Just know that it is a problem in the American Indian community, and colorectal cancer seems to be one of those cancers that you find a higher prevalence rate in the American Indian and the Alaska Native population. So again, the screening rates are low in this region. It is higher than most, but it still falls short of the 70% screening rate for the total age eligible population in Michigan. So when we talk about client reminders, they could be this letter, this postcard, email, telephone, any way that you're reaching out to the patient saying you need to be screened. Now, these interventions can be untailored to address the overall target population, which we'll talk to about in just a minute or so, or tailored with the intent to reach one specific person based on characteristics unique to that person related to the outcome of interest and derived from an individual assessment. So it can be general, it could be directive. Excuse me. So calculating screening rates, again, we discussed this on the last, during the last hour, kind of ran through this. There's two methods. There's the direct method, where everyone who, I say everyone, all active patients in that patient activity is either a year or 2 years, and that's usually defined by the payer or by IHS or by somebody that says these are considered to be active patients. The numerator are those people who got screened by an appropriate test. Again, I think that rates are lower than what they actually are. They're reported lower just because people getting screened, that the documentation of that screening is not always, for various reasons, part of the client's record. So there's the direct method and there's the sample method. So two ways of doing that. And so if you are going to reach out to your patients with these reminders, who are you going to select? Now, here, if we're talking about the client reminders, again, we're talking about a postcard, we're talking about a letter, we're talking about a telephone call, we're talking about a tweet. an IM, something directed to that patient. And when you're selecting the people, the first thing is you get all age appropriate people. So anyone between 50 and 74 are in this larger group. And you could reach out to all 50 to 74 age people in that age range, and they would all get the same message. But it's a generalized message. Screening is good for you. Have you been screened? Go talk to your doctor today. So the advantages to this, it's easy to generate a mailing list. You're sorting by one factor, and that is age, or date of birth is what you're sorting by. It's a simple generalized method. There's no need for confidentiality. So if you are sending a postcard and it just says, it gives general information about colorectal cancer screening, that could be an open face card, and we'll have some examples later on in the presentation. The drawbacks to that, you're reaching people that have already been screened, and so it may be that these people think, gosh, something went wrong, my screening didn't go right, I need to be screened again, or this clinic has lousy bookkeeping, they don't know what they're talking about, and it could just be viewed as junk mail. If you do the patient showing gaps in care, so those are patients who are out of compliance with their colorectal cancer screening. Either they've never been screened or their screening was not within the time frame for that particular test. The advantage, again, you're specific to this individual. You are overdue for your screening, and it usually gives this detailed call to action. Talk to your doctor today about being screened, or what test is appropriate for you. The drawbacks, or it's more difficult to compile this list. If you are telling this person that they are out of compliance with your screening, that cannot be on a open face card, because that would be a violation of HIPAA regulations. I'm looking at the section 1557 of the Affordable Care Act, and that has to do with non-discriminatory language. If it is both an open face card, kind of the general one, would need to comply with the 1557. If it's more direct, then instead of two languages that you have to have the message in, I think it's like 12 or 15. And so there's usually additional costs in the production and the mailing of these. So crafting the message, if you're going to do a reminder, what are you going to say? The NCRRT and the American Cancer Society several years ago went together and said, okay, we know there are people out there that are unscreened, and we also know that with any kind of compliance, there's always going to be that irreducible core of people, regardless of what you do or what you say, are never going to be screened, or never going to get a flu shot, or never quit smoking. But that's at the extreme. So here's this pool of people. Here's these people in the middle that may or may not be screened. And what do these unscreened people look like? What do they feel? What motivates them? And what messages come together that may persuade these people to take that step and overcome their resistance? So we know that there's a demographic profile and this emotional profile. So age, insurance status, income, race, ethnicity, education, and a cancer connection are all those demographic profiles. Those emotional profiles, they may be procrastinators. Yeah, I know I need to be screened, but I'm really busy this week and next week, and um, so they don't do it. I'm healthy. I have no symptoms. I'm fearful of preparation. I don't want to get a colonoscopy because I don't like the prep work, or I don't like digging in my own poop. So those are those emotional profiles. When you ask these people what these barriers are for them to get screened, you come up with these seven. These are the ones that uh, are have been identified. This rationalized avoidance. I'm okay. There's nothing wrong with me. Lack of affordability. So screening, especially for the unscreened, um, and the uninsured, it may be it may be that they can't afford that. Now, the Affordable Care Act, while we still have it, uh, colorectal cancer screening, these preventive cancer screenings are covered. The problem comes with the colonoscopy that it's a preventive screening until they clip that first polyp, and then it turns into a different code, and then people have to usually have a copay or something. So this affordability, no symptoms, a negative connotation. Doctor didn't tell me to. I have no personal connection with cancer, so I don't know how. If I get cancer, isn't that just like uh, getting the flu or getting scabies or anything? And so they don't know what it's like or have anyone there, and these low levels of healthy behavior. Okay. Motivation. So what motivates people? So the most effective messages needed to resonate with a priority audience, and they have to do it rationally and emotionally. Um, so these are six core motivators that were identified to get by the people to motivate the unscreened to get screened. Support and testimony, um, empowerment and control. Some people like to have that control in their lives. Um, they want to stay healthy, so especially if they're getting their flu shot, their mammogram, uh, watching their diabetes, keeping their um, uh, taking, yeah, taking care of themselves other ways than their blood pressure low. Trust, options, and again, affordability comes into it. So the not only talk to those who were unscreened, but the talk to those who were screened, and it's um, what are some of those things that if I knew or I do know, um, would I would be more likely to get screened. So those who were screened, 87% said my doctor recommended it to me and I did. And 46% in the unscreened said if my doctor would have told me, then I likely would have gotten screened. And it goes on down the list. Um, if you knowing that it's covered, if it's knowing it's recommended for the age, if it prevents cancer. And so from this type of information, NCCRT and the ACS started crafting these messages. And we know that um, the message the messages needs to focus on these things to um, uh, to have their effect on the unscreened. So um, addresses those misconceptions and has testimonies, those who have been screened. So yeah, I did get a colonoscopy, and it really isn't that bad. And then the providing them with the information and the knowledge that they need. So all that's part of the messaging that is going in to uh, to motivate people to get screened. And so these kind of boiled down are those three key messages. There are options. It's colorectal cancer is a leading cause of cancer death, and preventing it or being diagnosed at an early stage isn't that expensive. So if you take these messages and you look at why they work. So the first message, there are several screening options available, including simple take-home options. Talk to your doctor about getting screened. It empowers the patient. It eliminates these barriers, so it eliminates some of the fear. Um, and then it also gives these options that it doesn't always have to be a colonoscopy. It doesn't always have to be an annual FOBT. The other thing, it says talk to your doctor. So it's that trust factor is in there, and we all hope that we trust the healthcare personnel that we work with. And it's not saying talk to the American Cancer Society. It's not saying talk to the Intertribal Council. It's saying talk to your doctor who you already know and we would hope have a good relationship with. The second message just it highlights and it underscores that colorectal cancer is a leading cause of cancer death. So it's educating people. It's saying that it can be prevented or detected at an early stage through the screening, and it appeals to this desire to the people who want to stay healthy. It challenges the assumptions that colorectal cancer can't happen to me. So second leading cause of cancer death, yeah, it probably could. I'm trying to, off the top of my head, think of the prevalence of colorectal cancer, and it does escape me. It's the second leading cause of death. This is total population. The incidence rate would be below female breast cancer. It would be below lung cancer. So prostate cancer for men may have a higher incidence rate, but certainly it's in the top 4 for men and the top 3 for women. It also empowers the patient. So it gives the problem, but it also gives the solution. So here, it's a deadly disease. However, this is what you can do to make for sure that if you have it, it's detected early. Preventing the third message that resonates, preventing colon cancer or finding it early doesn't have to be expensive. So for the financially challenged, these are the low socioeconomic population that typically experience a disproportionate share of health disparities. They are also often restricted by high deductibles or do not have access to health insurance or underinsured. And again, with the Affordable Care Act and the the advent of the Healthy Michigan Plan, we have fewer uninsured people than what we've had before. But certainly for those people who are underinsured, this may be a problem. Now, they may not know that, again, the colorectal cancer screening is covered at no cost to them under the Affordable Care Act if they are insured, regardless of the type of insurance that they have. What we do know is that the uninsured are less likely to have received cancer screenings and are even less likely to receive follow-up care after a diagnosis. To motivate these financially challenged people, they are driven by control. This message about affordability tested high with this audience. Preventing colon cancer doesn't have to be expensive. Because this audience is either not insured or has an income of under $30,000 annually, messages around affordability will drive action as healthcare costs are a major concern for them. They respond to messages that promote alternative, less expensive options for screening. Message 4, most health insurance plans cover life-saving preventive tests. And again, this is appealing to those, they can be not only the financially challenged, but just people in general who say, you know, I really don't want to pay for this test because I'm healthy. For people that are newly insured, they may not know that they have this benefit. What we know of the newly insured is that they feel optimistic about their health after receiving coverage. And about 60% use their insurance to receive medical care or get a prescription filled within a few months after being insured. At a time when they are feeling newly empowered and optimistic, that's a great time to motivate them to get screened. So let's look at some examples. These may be a little bit hard to read. These are open-faced cards that went out to people, all age-appropriate people. So again, when we talked about, excuse me, who are you targeting? Are you targeting all age-appropriate people, or are you just targeting those in gaps in care? And because it doesn't say anything about the person is overdue for their test, for their screening, it's not subject to HIPAA. So the first card is from, excuse me, Make It Your Own, or Mayo. If you're not familiar with Mayo, you should be. It allows you to go in and select different pictures and different designs and different messages that not only can cover colorectal cancer screening, it could be mammograms, it could be PAP, it could be any kind of reminder for any kind of service that the health center wants to get people involved with, remind them that they need to do it. It is also, you can brand this, and so HCI is a health plan, and you can pop your own logo on there, and that goes out. So there's, in the resources, there's a link to Mayo. These on the right are some that ACS has used. Again, it is a general message, and the message is many colon cancers could be prevented or found early through regular screening tests. If you are 50 or over, it's time. Talk to your doctor about being screened. So again, it gets around HIPAA, that it does not say you are overdue. With the ACS ones, you can see that the top two are branded with Blue Cross Complete, and the bottom one is co-branded with Harbor. Um, ACS has this ability to put different pictures based on the population that you're serving. So people want to they respond better when the message comes from people who look like they do or talk like they do. And so with both of these, with the Mayo and the ACS cards, there's a there's a gallery of pictures, and people can select which ones and pop them into the template. You'll also notice in the ACS one, there's a space here. So if they wanted to say something more than this one message, if they know that this particular patient visits a certain clinic, then it could give the name and the address and the phone number of that clinic. I like these two that says talk to your doctor. So again, it's that trust factor. It's not ACS saying go get screened. It's not Mayo saying go get screened. It's talk to your doctor about it. They know the best. Now you'll notice on this one, when I mentioned 1557, you have to for the non-discriminatory language, you have to give patients who may not read English or know English, you have to give them the ability to see what that message said. And so Harbor popped in these two languages. I know you can't read them from there. One is Arabic and the other looks like Spanish. And so again, depending upon, since this was a postcard, you could get away with a limited number of languages. If it's a detailed letter, then it's the 12 or 15. So now, if you wanted to use these for gaps in care, people showing gaps in care, you could do it two ways. You could not mention that you're overdue. You could send the same card to people that are overdue for their screening or haven't been screened, and it still has this general message to it. If you want something that says you are overdue, then you have to go to a bigger postcard that folds over and it's sealed. And those are available too. Another way of again, you're utilizing the mail is a letter, and I know you can't read this. I like this letter because it captures some of those messages that we talked about. So this is from a health plan, and it's from their medical director, and it's to it is a general letter, so it doesn't say you are overdue for a screening. That language could be inserted in this if you want. It could be sent to everyone age appropriate, or it could just be sent to those showing the gaps in care. So it starts out, I know you don't like a colonoscopy, but that's not the only way to be screened. There are other options, and one is this FIT kit, and it's a stool test, and you don't have to prep for it in any way. You can eat what you want, as opposed to the old FOBTs. And instead of taking 3 samples as an FOBT, you only have to do 2 samples, and maybe you only have to do 1, and that depends on the FIT kit. So it's giving people an option. It's giving them it's kind of taking away and knocking that stool out from under them that's saying, well, I'm not going to be screened because I don't want a colonoscopy. There are other ways to be screened. The second thing that they addressed is, he mentions both tests are covered by your insurance. So you don't have to worry about paying for this. It's already paid for. There's no cost to you. Now, if a health center was sending out a similar letter, the language would want to be changed um, to be more general in nature. I don't think you want to guarantee that there's no cost to somebody, because those are going to be the people that go in for the colonoscopy, and it's going to be from a screening, it will be converted to a diagnostic because they have to cut out a polyp and they're stuck with a $300 or $400 copay. And then it gets this other thing. This is why you need to do it, because it's the second leading cause of cancer deaths, and it's 90% curable. So it's not one of these uh, tests that you go in and yeah, you have it, and um, because this is such a deadly disease, your chance of survival is low. It's if you catch it early, if you get screened on a regular basis, then that's catching it early, and you have this 90% survival rate. So this letter gets those different messages out. So you could okay. So there we go. And then there are other ways to reach these. So a lot of this is small media, what they would call small media. So banners that you could have in your office, social media toolkit. So if you decide you don't want to send people things, but you have their cell phone number, and that cell phone number can receive text, then you may be texting messages to them. Now, those messages would need to be more compact than the letter. You could probably get away with what you're doing on the postcard, but the social media toolkit by George Washington Cancer Center has all that kind of stuff in it. Um, if you're doing general outreach, and again, this would come under more the small media, radio scripts, um, infographics, and these types of things. You could also do telephone calls, and telephone calls again would want to utilize the same types of messaging. And you can, again, you would need to decide, are you doing these for people showing the gaps in care, or are you doing this for the whole age eligible population? If you're doing it for the whole age eligible population, you may want to look into automated calls. Now, automated calls are okay, and the some insurers use these all the time. They're cheaper than having an in-person call, and they've seen moderate success in motivating people. So here it's just more of a reminder. It would work more with people who have been screened in the past, who have let that screening lapse, than new people. For the unscreened, if you can't afford it, the in-person or the live operator calls are usually good. And the reason why is that they can interact with the patient. So it's not somebody calling and spouting off the 20-second message and saying have a good day and hanging up. There would be follow-up questions. So are you likely to get screened now that you've heard this information, now that you know there are options in screening? Are you more likely to get screened, or less likely, or about the same? Or are you confused by what exactly a colonoscopy entails as opposed to a fit kit? And as you, if it's done more of this survey method, these answers can be recorded, and soon it becomes some of these responses you can group together. That you may get the response that, hey, I didn't know that I could take a stool test and that counts and that it's covered. So yeah, I think I am going to be screened. Well, at that point, then you would naturally ask them, well, can we send you a kit, right? Or when you're in the doc, I'll make a note of that and give it to your doctor, and the next time that you're in, we'll give you a kit. So they're more than likely. Or if it's the response is, I still don't want to be screened because of this and that, or whatever, then those responses could be grouped together, and you can see what what is on people's minds more than anything. Now, what this communications toolkit has done through the focus groups, it's taken a lot of that off of has already collected a lot of that information. So you already know some of those reasons why people aren't being screened. But if you think your population is unique and you have the way the financial resources to do this, because no one in your office, I'm guessing, has the time to call anybody, then the in-person uh, phone calls may be better. Um, I was involved with a project in Indiana about 10 years ago that we did the in-person uh, calling to people, the live person, and it was for a particular practice, and the screening rates went up 69%. So there is a lot of power to that. Okay, so we talked a little bit about in the first hour this recommendation that people, they need to hear it from the provider. So again, these client reminders that are going out are telling people to talk to their doctor about what screening test is best for them. And if your clinic is already doing this provider uh, reminder and recall, then people are going to be coming to you anyway asking about this. Okay, so assessing. So if you're implementing this, you want to know if it works, right? So again, going back to the first session, once you decide this is a priority and you're putting things together, your strategy, you need to plan, you need to act, you need to study, and you need to adjust. So you may be including a logic model. You may have this time frame. You may want to evaluate the interventions together. If you're doing more than one intervention, you can either evaluate them together or separately. Why exactly are you being screened? Because the doctor told you, or are you doing it because you got this reminder, or so whatever. So what do you want to know? You want to know how many people were screened. You also want to know why people didn't get screened. And again, the communications guide goes into a lot of this information of the reasons people are unscreened. But you may want to hear it directly from the patient. Gosh, I recommended when you were here last time, we talked about you getting a colonoscopy. I have no record in the chart that you have been. Did you get it? No. Why not? So it opens up this conversation. You want to do a collection data table. You want to know. So again, a lot of these resources have those templates already there for you to use. What period are you looking at? From whom? What you really want to know is you put this plan into effect, and as they say in the South, was the juice worth the squeeze? So you've done all these efforts. You might have done phone calls. You might have mailed client reminders. You did it have an effect? Can you isolate that? Can you say this was the reason this person is now screened? And if it has no effect, then you go back to that. You need to find out why and adjust what you're doing. So that is kind of a brief overview of client reminders. Again, um, they work when we have done them primarily with health plans here in Michigan. They do see an increase in their screening rates. Um, we don't know, unfortunately, we don't know if it's, does the ACS brand have an extra value to it, as opposed if it was just branded by that health plan. Anecdotally, the health plans tell us um, if it's just from the health plan, then it somehow it lessens the message in some way. However, if it's coming from your clinic, um, you are the people that are dealing with this patient every day. They're familiar with you. There's this element of trust there. So if it comes from you and it has your brand on it, then um, that would be, I think, more meaningful than anything coming from the health plan or from ACS. Now, you're certainly welcome. I know your health plans would be happy to co-brand with you on something like that. We would be happy to. It may just not be necessary. Um, they do work though, reminders. If you're not doing them now, by all means, I would recommend that you look into it. You could start small. Postcards are not that expensive, especially the Mayo. You don't have to pay anything to use the template. So really, the only thing that you're looking at is the cost of postage and the printing. Um, so relatively cheap for getting those results. I would highly recommend this communications guidebooks. So most of what I talked about today, the information on the messaging, what works, what's the motivators, have been taken from this guidebook. And that, along with everything else you always want to know, is available at the NCCRT. Um, Again, as Mike has mentioned, there's a resource page, a document, a Word document that has the URLs embedded in the title. So all you have to do is click on that and take a look. So at this point, I will stop and entertain any questions you may have.
Alrighty, thank you, Tom. So if you have any questions, feel free to go ahead and post them into the question box on the lower right portion of your screen. And as we mentioned, we do have the PDF, which is available of the PowerPoint presentation from today. That is in the handouts area on the lower right-hand portion of your GoToWebinar control panel. And we also have the resources that are also on the lower right-hand side of the GoToWebinar control panel. And we're also going to be archiving this webinar as well. So if you know of anybody that wanted to attend the webinar today but was unable to, we'll be archiving the webinar on itcmi.org. And I'll go ahead and send a follow-up email to everybody with a link to it so that you can go ahead and check out the webinar throughout the week, next week, whatever. I'll probably get it turned around later on today. Also, if you wanted to receive continuing education units, we will be sending out a post-webinar evaluation tomorrow. So go ahead and click the link in the email blast that goes out tomorrow from GoToWebinar. And within that email, there'll be a link. You click the link, they'll take you to the evaluation. And then after about a week, I'll go ahead and get the evaluation turned into IHS for your certificates. So, well, so far, Tom, I don't see any questions popping up in the question box here. Did you have anything you wanted to add while we wait on that?
No, just if anyone has any questions, my email address is listed at the end of the presentation. Know too that my email address, my phone number. Know too that we have field staff. Many of you are familiar with Dave Igley and maybe Andrea Castle, and Dave works with the tribes, and Andrea works with with some of the health systems in the UP and the northern part of the state. If you would like one of them to come into your clinic and give you more information, or if you're looking for the toolkits and there's just too much on the NCCRT website to find them, again, you can either email me or call me. I can either send those to you, or I can put you in touch with Dave and Andrea.
Excellent, excellent. Well, I don't see any questions being typed in as of yet, so I'm thinking this might almost be a good time to go ahead and wrap it up. What do you think, Tom?
I think so.
All right.
Thank you for the opportunity. I'm half hoping that this isn't new information that you're hearing, but that it just reinforces information that you have heard before. I would, I know all the centers have priorities and competing tasks to do. I would encourage you to make colorectal cancer screening one of those priorities, and by all means, talk to your peers, talk to those tribal health centers that have already done this and have raised their rates. They will be able to give you a lot more practical information than what I was able to do over the past couple hours. So good luck with all that you do, and enjoy the snow up there.
Thank you very much, Tom. And with that, we'll go ahead and wrap it up. Again, feel free to fill out the webinar survey. We'll be sending out a link for that tomorrow as a follow-up email from today's presentation. So make sure you fill out that survey if you want to get your continuing education certificates. And we will also be archiving the webinar, and I'll send out a follow-up email to the email list that we sent out the initial webinar invitations out to. So with that, thank you very much, and we hope everybody has a wonderful rest of the day.